Hi, good morning, good evening, good afternoon, wherever you are. Welcome to the ICH Junior Club. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it is my great pleasure to welcome you to this activity by the ICH. And usually this is Professor Florent Mallard, who is the moderator of this, but I had to jump in today because he had some good news, a new baby. So congratulations, Florent. So I'll try to do my best with our distinguished guest today, Dr. Chakraborty and Dr. Suzanne Lentzsch from the University of Columbia in New York. So thank you both for joining us. It's a great pleasure and an honor to have you with us. And the concept, I think you're becoming familiar with this junior club. It's about a rising star, a brilliant junior colleague who will present an interesting clinical case, sort of a real life case. How did they do the diagnosis? How did they manage it? And then after the presentation, there will be a conversation between the presenter, but also the expert in the field. And I'll try to moderate all this. So without any further delay, it is my great pleasure to welcome Dr. Chakraborty. Please share your slides and tell us more about your case. Thank you.
Thank you, Dr. Moti, for the kind introduction, and thanks for providing this platform to present this case on AL amyloidosis. Today, I have the pleasure of presenting this challenging case of systemic light chain amyloidosis that we had seen, I had seen in my clinic about almost 1.5 years ago now. And as we go along, we will go over some of the literature for the diagnosis and management of AL amyloidosis in 2022. So this is the case. A 77-year-old African-American female presented to our hospital in July 2021 with a constellation of symptoms, including a worsening shortness of breath for about a few months. She also noted some cloudy and frothy urine, had worsening edema in bilateral lower extremities, and really debilitating fatigue. So she was a very active, although she was 77, she was still working part-time. She was a teacher, and she used to still work and do quite a good amount of physical activity. But for the past 3 to 4 months before she presented to us, she had been mostly laying in bed with debilitating fatigue and with all the other constellation of symptoms. So she was seen by cardiology at Columbia, who performed a transthoracic echocardiogram, mainly because of the worsening shortness of breath, that showed a very thick intraventricular septum of 1.8 centimeter. Of note, she had a prior history of hypertension, but it has always been well controlled on one medication. She never had a history of uncontrolled hypertension in the past that would explain such a thick intraventricular septum. She also had a very thick left ventricular posterior wall of 1.7 centimeter, and the ejection fraction was slightly hyperdynamic, was 70 to 75%. Based on the echo, cardiology had a very high suspicion for an infiltrative cardiomyopathy, and that's why she underwent a right heart catheterization and endomyocardial biopsy, which confirmed AL lambda amyloidosis. At that point, she presented to us, she was referred to us once the AL amyloidosis was already confirmed on the endomyocardial biopsy. And we performed the hematology workup, including serum kappa lambda light chains, immunofixation, both in serum and the urine, and also a 24-hour urine protein. And as you can see here, her serum lambda light chain was significantly elevated with a DFLC, that is the difference between the involved and uninvolved free light chain, of almost 60 milligrams per deciliter. So significantly high DFLC. And also she had a serum M spike of IgG lambda of 0.8 grams per deciliter. And she had a lot of proteinuria, more than 8 grams of proteinuria and 24-hour urine protein, which was almost all of that was albumin, was 95% albumin, and about 4% was Bence-Jones protein. Again, a phenotype which is consistent with renal amyloidosis here. Then after that, we confirmed the diagnosis of a plasma cell dyscrasia with a bone marrow biopsy, which showed 20% plasma cells lambda restricted on core biopsy. And then FISH was done, which showed hyperdiploidy, monosomy 13, and also showed gain 1q with 3 copies of 1q. And I'll go over later on why that was important. And then we did the biomarkers for organ involvement to look for her baseline organ involvement. Her NT-proBNP was significantly elevated at 5,087 picogram per ml. High sensitivity troponin was 50 nanogram per liter. Her 24-hour urine protein, as I had already mentioned, was more than 8 gram. Her EGFR was slightly reduced, was 48. Not significantly, but slightly reduced. Alkaline phosphatase was normal at 59 units per liter. She had no orthostatic hypotension. However, her systolic blood pressure was slightly on the lower side of 104 millimeters of mercury, but was more than 100. So with that background of the case, and we will come back to the case, so what is amyloidosis? And amyloidosis is a constellation of many different disorders. There can be more than 30 different kinds of amyloidosis, but the basic principle behind all of them is the same. That is, there is a native folded protein, which in its native state is usually not amyloidogenic, but something happens. For example, there could be a mutation in the gene encoding the protein that changes the physicochemical properties of the protein, and that leads to amyloidogenic properties in that protein, and subsequently it gets deposited in vital organs, for example, the heart and the kidney, as beta pleated sheet structure. So if we focus on AL amyloidosis, which is our topic today, it typically originates from the clonal plasma cells, which secrete the immunoglobulins as well as the light chains. And sometimes what happens is these light chains are kinetically unstable due to some mutation in the light chain genes, and due to altered physicochemical properties of the light chains, they become extremely amyloidogenic and subsequently deposit in heart, kidneys, liver, and other vital organs and cause end organ damage. So this is a study, this is one of the seminal studies on incidence of AL amyloidosis that was performed by Dr. Kyle and group at Mayo Clinic, looking at the incidence of AL amyloidosis in Olmsted County, Minnesota. And as you can see, over time, since 1950 to 2015, the incidence of AL amyloidosis per 100,000 person years had slightly increased, although the trend in increase was not statistically significant, but numerically you can see that there was a slight increase in the incidence over the years. And this translated into approximately 4,000 cases per year, with the caveat that this was a predominantly white population. So we are not sure what the exact incidence would be in a more heterogeneous population, including African Americans, Hispanics, and Asians. But overall, about 4,000 cases per year. And on the right side of the screen, you can see that the incidence clearly increases with age, and also the incidence is higher in males compared to females. In their cohort, they had found that the median age at presentation was 76 years. So was much higher compared to some of the other studies which have included a more diverse population, where we see that maybe the median age at presentation may be slightly lower than that, but it's typically a disease of the elderly. This is one of the figures that I like a lot. It was presented by Dr. Merlini in the Ham-Wasserman lecture, I believe in ASH of 2017, which tells us a lot about the biology of AL amyloidosis and the rationale behind our current approach to treatment. So these are in vitro studies which showed that which showed the kinetics of fibril formation in AL amyloidosis. And you can see there are 3 distinct phases. There is the lag phase, then there is the nucleation or the log phase, and finally there is the elongation phase. So basically in the lag phase, what happens is that there is amyloidogenic light chain present, but the conditions are not favorable, or maybe they have not reached a critical concentration for rapid nucleation or rapid fibril formation. Then you have the nucleation phase, which is likely when many patients would present to us, when the conditions are favorable for amyloid fibril deposition in the organs, and also the critical concentration has been reached that there is rapid fibril formation causing rapid deposition in the organs and end organ damage. And finally, there is the elongation phase, when the elongation of the fibrils can continue even with a very, very low concentration of the substrate or the amyloidogenic protein. So what are the clinical correlates of these 3 different phases? So as you can see in the lag phase, this may be an area where we can perform early therapeutic intervention if we knew that a patient with, let's say, smoldering myeloma or MGUS has an amyloidogenic light chain that in future may cause end organ damage. Currently, we don't we don't know precisely who is going to have amyloidosis versus who is not, and there is research going on regarding that, but this could be an area for early therapeutic intervention potentially. Then in the log phase, that this is the phase where we really need early detection and rapid and deep hematologic response to drive down rapid nucleation and fibril formation. And finally, the elongation phase basically highlights that we need a sustained deep hematologic response. Merely a partial response or a 30-40% decrease in light chains is not enough, because even at a very low concentration of the amyloidogenic clonal light chain, the elongation of fibrils can continue. So this figure basically tells us a little bit on the rationale as to how and why we treat AL amyloidosis. Then we'll go into the diagnosis and management. As we have already said, the clinical presentation, heart and the kidneys are the two most common organs. And the presentation of amyloidosis can be extremely protean. As you can see, it can present with symptoms of heart failure to symptoms of nephrotic syndrome, sometimes can affect the nervous system. Nowadays, we rarely see patients presenting with severe macroglossia, given we are hopefully doing a better job in diagnosing these patients early. But certainly macroglossia is a classical sign of AL amyloidosis, and also in liver involvement can cause hepatomegaly, increased alkaline phosphatase, and GI involvement can cause malabsorption, weight loss, and also bleeding because of factor 10 deficiency. So these are some of the clinical pearls as to when we should think of AL amyloidosis. So whenever a patient with monoclonal gammopathy, especially a lambda clone, presents with any of the following signs and symptoms, at least AL amyloidosis should cross our mind at some point during the workup. Some of them are fairly straightforward. For example, heart failure, progressive unexplained proteinuria, but some patients that we see in the clinic, one of the classical things that we hear is that, doc, I used to be hypertensive, but my blood pressures have been low lately. And they have been told that their blood pressure has been extremely well controlled. But that could be a sign of amyloidosis brewing, especially in a patient with lambda light chain monoclonal gammopathy, because these patients have decreased cardiac output that can manifest as low blood pressure. Also, unexplained orthostatic hypotension, unexplained nausea, vomiting, and diarrhea. All of these could be the signs of AL amyloidosis. Then the next question is, when we see a patient in the clinic, is which site to biopsy for diagnosis. Now, at Columbia, we are a referral center, so we sometimes get patients, for example, this patient, where the organ biopsy has already been performed. So by the time the patient is coming to us, an organ biopsy has already been performed and diagnosis has been already established. So what do we do in those cases? So if organ biopsy already performed, and if the organ biopsy is negative, then amyloidosis is extremely unlikely. The false negative rate in organ biopsy is extremely low. It's not zero, but it's extremely low. And if the organ biopsy is already performed and it's positive, that means amyloidosis, AL amyloidosis is confirmed. In that case, we still need to do a bone marrow biopsy before we initiate treatment because of two reasons. First of all, bone marrow biopsy will confirm that there is a plasma cell clone because we are using a plasma cell directed chemotherapy. About 1 to 2% of patients with AL amyloidosis could have, for example, a lymphoma or a CLL clone making amyloidogenic light chain. So we need to know which clone we are treating. And the second thing is that we do get some important prognostic information. For example, the percentage bone marrow plasma cells, the FISH abnormalities, which tells us a little bit as to how a patient is going to respond, or if we can use venetoclax, for example, if the patient has T1114 down the line. So it gives us a lot of information. That's why we still need to do a bone marrow biopsy before initiating treatment. And what if organ biopsy is not performed and patient is sent to us just because there is monoclonal protein present and there is clinical suspicion by another provider for AL amyloidosis? In that case, we typically do a fat pad and a bone marrow biopsy together, because doing them together has a higher sensitivity compared to doing them one after the other. And also it helps us in establishing a diagnosis quicker, avoiding wasting time. If one is negative, then doing another takes another week. So our goal is basically in these cases to get to a diagnosis as quickly, as safely, and as parsimoniously as possible. And of course, if it's positive amyloidosis is confirmed, if fat pad and bone marrow is negative and clinical suspicion is strong, we still need to do organ biopsy if there is a high clinical suspicion before dismissing that this is not AL amyloidosis. So I'll quickly go over these slides. There's how to make a tissue diagnosis. Of course, the step one is light microscopy. The step two is convoluted staining, showing a characteristic apple green birefringence under polarized light. But this is not enough, because even amyloidosis, which is not AL, for example, TTR amyloidosis, can also be convolute positive. So we really need to type the amyloid, and that's where the step three comes in, which is mass spectrometry to identify the origin of protein. And in the US, most centers are sending this mass spectrometry testing to Mayo Clinic. Sometimes in specialized centers, we also do immunofluorescence or immunohistochemistry, but the teaching is that mass spectrometry is the gold standard. And for all practical purposes, we should be sending all specimens of suspected amyloidosis to Mayo Clinic for mass spectrometry for accurate typing, because every subtype is treated differently and it has therapeutic implications. I had already alluded to this earlier. The sensitivity is based on the biopsy site. And as you can see, this is a paper from Mayo Clinic published by Eli Mukhtar and colleagues, showing that the fat pad and bone marrow biopsy, when done together, have a sensitivity of, excuse me, of 89%. Whereas it's much lower when they are done individually. And they also found that omission of fat pad biopsy was usually a predictor for the need of organ biopsy. And given fat pad biopsy is straightforward, is less invasive, and much safer, we would rather prefer to have a diagnosis by fat pad biopsy than a kidney biopsy, which has a 5% risk of retroperitoneal hemorrhage. So what initial workup do we do in these patients? And as you guys have already seen in my earlier slide regarding our patient, but we typically do a monoclonal gammopathy workup. We do a cardiac workup, including NT-proBNP, troponin, echo. Cardiac MRI is not mandatory, but we often do it. And also, this is not in the guidelines, but we often do either a Zio patch or a Holter monitor to rule out occult atrial fibrillation, since these patients are at a risk of occult AFib, which can lead to cardioembolic stroke. And in that case, they need to be on anticoagulation. So we often do this. I at least do in all of my patients with stage 3A and stage 3B AL amyloidosis. Then kidney workup, including 24-hour urine protein, liver workup, nerve. So nerve is usually clinically diagnosed. We don't routinely do EMG or nerve conduction studies unless patients have that as a primary manifestation and they are already seen a neurologist and already had that done. And if somebody already had an EMG done, that will typically show an axonal pattern in the AL amyloidosis, as opposed to, for example, a demyelinating pattern in Poem syndrome or MGUS or IgM-associated neuropathy. For GI, again, it's mostly a clinical diagnosis, but you could do 24-hour fecal fat or GI motility studies, not routinely done in the clinic. And finally, hematology, of course, we do a PT-PTT, factor 10 level, and a bone marrow biopsy, aspiration biopsy with FISH testing. Next, we will go on to risk stratification, and you will see that the predominant theme in all the staging systems of cardiac amyloidosis is that cardiac involvement drives mortality, and that's why those are heavily weighted on all the staging systems. This is the 2004 staging system, showing that patients with stage 3 disease, that is a high NT-proBNP and a high troponin, they had a 1-year overall survival of almost 20%, which was dismal 1-year overall survival. And of course, the patients who were stage 1 disease, neither of them were high, they did much better. And this was the Mayo 2004 staging system. This was subsequently refined by the European group into stage 3A and stage 3B based on the NT-proBNP cutoff of 8,500. They also showed that patients with systolic blood pressure of less than 100 at diagnosis, they did poorly. So if you recall, our patient had a systolic blood pressure of 104 millimeters of mercury, so definitely on the lower side, but more than 100. And this is not included in the staging system, however, but it's clearly demonstrated that systolic blood pressure of less than 100 is a bad prognostic factor. Similarly, a global longitudinal strain, which is measured on the echo, we also know that patients with a less negative global longitudinal strain at diagnosis, this was shown elegantly by the UK group, they had a worse prognosis overall, and it can actually add to our current staging systems. Then we have the Mayo 2012 staging systems, in which we added DFLC, or difference between the involved and uninvolved free light chain, to the NT-proBNP and troponin, and it leads to 4 different stages: stage 1, 2, 3, and 4. And the stage 4 patients have a median overall survival of only 6 months. So a really dismal prognosis at that time, whereas stage 1 patients had a median overall survival of approximately 94 months. So back to our patient. So if we go on to the staging of our patient had a DFLC of almost 60, so clearly more than 18, so gets 1 point for that. then also had an NT-proBNP of more than 1800. So definitely gets 1 point for that, and high sensitivity troponin of 50. So our patient was Mayo 2004 stage 3A and Mayo 2012 stage 4. So it was an extremely high-risk patient. If you go back to the staging systems in Mayo 2004 stage 3A, let's go back to this 2004 stage 3A. So if you see here, the 1 year overall survival is roughly about approximately 50%. And if you go to the Mayo 2012 stage, the stage 4 has a 1 year overall survival of approximately about 40%. So really bad prognosis at diagnosis in this patient given the advanced stage. Then finally, a quick note on the renal staging. So renal staging is not used to decide on prognosis as far as survival is concerned, but it does predict very well the chances that a patient will end up needing dialysis. And it's basically based on two parameters. One is proteinuria and second is the eGFR. And patients who have a proteinuria of more than 5 gram and eGFR of less than 50, they have a 3-year risk of going into dialysis of 60%. And our patient was stage 3, a renal stage 3 at presentation. Then we'll move on to treatment. So the treatment in AL amyloidosis primarily involves, at least as of now, involves killing of the amyloidogenic light chain producing plasma cell clone using a myeloma type treatment or a plasma cell clone directed chemotherapy. And that leads to what we call as a hematologic response, that is decrease in the light chains. And our ultimate goal is to achieve an organ response, that is improvement in the organs, primarily heart and the kidney. So I will quickly go over the historical context to set up a historical context on the randomized controlled trials on clone-directed therapy in newly diagnosed AL amyloidosis. And as you can see, the first study was done in 1978, and that compared melphalan prednisone to prednisone, and the organ responses were higher with melphalan prednisone, but there was no survival benefit. Then subsequently, the third study here, which was melphalan prednisone colchicine versus melphalan prednisone versus colchicine, that was published by Dr. Kyle in 1997. That study primarily established melphalan prednisone or melphalan dexamethasone as a standard of care for AL amyloidosis. It showed that MP was equal to MPC, and both were superior to colchicine alone as far as overall survival was concerned. Then the question in the field was that if standard dose melphalan works, will high dose melphalan be better? And there was a randomized trial done by the French group, but unfortunately that trial was negative, primarily because there was a really high treatment-related mortality in the transplant arm of approximately 24%. Just to set the context, the current transplant-related mortality is much lower, is roughly in the ballpark of 2 to 3% at centers of excellence for AL amyloidosis. Then subsequently, the bortezomib era, the Chinese investigators did a study of bortezomib dex versus no induction prior to transplant, and the overall survival was superior with bortezomib dex. And then subsequently, there was another study doing on bortezomib melphalan dex versus melphalan dex, which again confirmed a superior overall survival with bortezomib melphalan dex. And that kind of established BM dex or bortezomib melphalan dex as standard of care in Europe. In US, Cybody or Cytoxan bortezomib dex was more popular as a standard induction regimen. And that's why Cybody was chosen as the control arm for the pivotal daratumumab study, that is the Andromeda AL trial, that is applicable to our patient, as I will show you in the next slide. So this was a randomized trial comparing Cybody to Cybody, which showed the response rate and the progression-free survival were both superior with Cybody. The overall survival results are still immature, but it's trending in direction of favor of Cybody over Cybody. So this is the Andromeda AL trial. So as you can see, this included patients with stage 1 to 3A AL amyloidosis. So our patient would have been eligible for this trial. She had stage 3A AL amyloidosis and had largely preserved organ function. And then these patients had 1:1 randomization to Cybody versus Cybody. One important caveat is that after 6 cycles, patients in Cybody arm received no maintenance, whereas patients in the daratumumab arm received another 18 months of maintenance for a total of 2 years of treatment in the Cybody arm. And the maintenance is not really established as a paradigm in AL amyloidosis, unlike in myeloma. So it becomes a little bit tricky to identify whether those 18 months of maintenance are needed or not, given there was no second randomization after 6 months. But overall, it was Cybody versus Cybody, 2-year treatment versus 6 months treatment. And clearly the study met its primary endpoint, and it was actually a dramatic improvement in complete response rate, about 3 times. And also the major organ deterioration progression-free survival, which is a clinically meaningful endpoint, was also superior with daratumumab compared to control. And as I alluded to earlier, the overall survival results are still immature, and we are eager to see longer follow-up with the overall survival data on daratumumab versus control. And this was the first FDA approval in AL amyloidosis. Then the next is how to assess response. And the important takeaway here is that the depth of hematologic response matters a lot in AL amyloidosis, perhaps even more than it matters in multiple myeloma. And PR is not enough. That's also another important takeaway. If you see here, patients with partial response, that is only a 50% decrease in DFLC, had a significantly worse overall survival compared to patients with VGPR or patients with CR. And also, this is a study done by the UK group, and it is all similar findings have also been confirmed by the Mayo group, showing that even within patients who achieve a VGPR or CR, a stringent DFLC response, that is a DFLC of less than 1 milligrams per deciliter, is desirable, given even patients who have a DFLC of 1 to 4 milligrams per deciliter at best response, they do worse compared to patients with DFLC of less than 1 milligrams per deciliter or less than 10 milligrams per liter. And this is true both for overall survival as well as time to next treatment. So our goal currently, when we are treating a patient with AL amyloidosis, is to achieve ideally a hematologic CR, but not only a hematologic CR, we also want to achieve a DFLC of less than 1 and an IFLC or involved free light chain of less than 2, considering the renal function is normal. If renal function is abnormal, of course, IFLC of less than 2 would be hard to achieve, but then we will go more by the DFLC. And regarding organ response, the important takeaway is the cardiac response is what dictates survival. A renal response is important because that does dictate long-term hemodialysis dependence, but for survival, cardiac response is the most important. And currently it's defined as 30% decrease in NT-proBNP from a baseline of more than 650 and an absolute decrease of at least 300. And this is the data from the pre-daratumumab era showing that organ response takes time, and the median time from treatment initiation to initial organ response is about 9 months for cardiac, 6 months for renal and hepatic. This number may decrease now with daratumumab as we are achieving very quick, very rapid and deep responses, but at least in the pre-daratumumab era, these are the numbers that we typically quote to patients. So back to our patient. So our patient started on Dara-Body and or Dara VCD. Her initial DFLC was 60. At best response, about 6 cycles after treatment, her DFLC came down to 10.8. And at that point, she had plateaued. So it was not going to go down any much lower. So as you can see, this was a PR because there was a 50% decrease in the DFLC, but not a VGPR because the DFLC is still more than 4. So if you go back to the response, you can see that patients who had a PR or partial response, they had a significantly worse overall survival compared to patients with a VGPR or patients with CR. And hence, PR is not enough. So we are clearly not happy with this response. And that's an important takeaway message here, that if a patient with amyloidosis, we treat and DFLC has come down even by 60-70%, but still the patient has not achieved at least a VGPR, ideally a CR, we need to give the patient rescue treatment. It's not enough. We cannot be satisfied with that response. So I'll take a segue here to quickly go over our approach at Columbia Multidisciplinary Amyloidosis Center that led by Dr. Lentzsch that we had devised after several rounds of discussions within our group. So all of our patients currently stage 1 to 3B, irrespective of transplant eligibility, we start them on Dara-Body induction. In patients who are transplant eligible, after 2 cycles, we refer them for consideration of transplant. In patients who are transplant ineligible, which is about 70 to 80% of patients, we continue the Dara-Body induction for 6 cycles. And as you can see here, if patients don't meet these milestones, for example, less than a partial response after cycle 2, less than a VGPR after cycle 4, and less than a CR or a DFLC less than 1 after cycle 6, we do strongly consider early rescue therapy in these patients because time is critical in these patients. We can't let the light chain circulate in the blood for too long, causing ongoing organ damage. And then at the end of 6 cycles, we perform bone marrow biopsy with MRD assessment. We are doing mostly with flow cytometry in these patients. We also send for adaptive NGS, but the data on that is not very clear. But at least with the flow cytometry, if they're MRD negative, we don't give them usually daratumumab maintenance. If they're MRD positive, then we typically follow the Andromeda trial. We give them daratumumab maintenance, maybe not for the full 18 months, about 1 year, and stop at that point if they are in a CR. And one important thing about transplant is the role of transplant is now less clear. And I would be curious to see what Dr. Moti and Dr. Lentzsch thinks about the role of transplant in the current era, given that there was a recent document saying that patients who achieve a CR with Chakraborty in those patients, maybe we should defer transplant. But again, there's a lot of controversy in the field about that. And the answer is not clear, and the practice differs by institution. So at least at the Mayo Clinic, this is the criteria they follow for transplant eligibility, age, ECOG, systolic blood pressure, troponin, and creatinine clearance. And then quickly, our approach to relapse refractory AL amyloidosis, we primarily determine based on cytogenetics, that is T1114. If patients have T1114 present, we usually prefer venetoclax as the rescue treatment, given it's safe and really high response rates in this subset. And if it's T1114 absent and patient is transplant eligible, in those patients, we strongly consider transplant as a rescue therapy. And of course, if T1114 present or T1114 absent, we could always consider IMiDs. POM is preferred over LEN. Reuse some of the earlier treatments if it's a late relapse. And I've put an asterisk over belantamab mafodotin because it's now taken off the US market. But in selected patients, we have used belantamab mafodotin in a very at a lower dose and with less frequency, like Q6 to 8 weeks. And we have seen good responses. But of course, it's taken off the market now. So it's not clear whether we will have continued access to this agent for AL amyloidosis. So this is a brief overview on the single agent response rates. And by response rates, I mean VGPR or better in relapse refractory AL amyloidosis. You can see the highest is with venetoclax in T1114 patients, 73%. Belantamab in a small series of patients was 55%. And we also have pomalidomide, 38%, bendamustine, 29%. Ixazomib and carfilzomib is less relevant currently, given we already use bortezomib first line. So if patients are refractory to that, they're likely not going to respond to another PI. And carfilzomib has cardiotoxic side effects. So it's very unlikely that we are going to use that in AL amyloidosis. This is a slide on a multi-center retrospective study led by Columbia, in which you can see the venetoclax-based combinations in T1114 AL amyloidosis had a 78% VGPR CR rate in relapse refractory setting. And based on these preliminary data, we are currently doing a clinical trial of phase 1 and randomized phase 2 on venetoclax in relapse refractory T1114 AL. So we will get hopefully some prospective data in the future. So back to our patient. So since we were not happy with the response, we added POM dex at this point at when the DFLC was 10.8. You can see the POM dex did not do anything. Her light chain did not drop at all. It was down to 10. And at that point, we gave her belantamab mafodotin. And with the belantamab mafodotin, it dropped by roughly about 50% from 10 to 5, but she has still, unfortunately, not achieved a VGPR yet. And because she has not achieved a VGPR, as you can imagine, her heart is still in a very bad shape. She has not achieved a cardiac response. NT-proBNP is still very high. And currently, we'll love to discuss what can we do next after this. And this is a slide showing that patients with GAIN1Q, which our patient had, they had an inferior overall survival and progression-free survival with daratumumab-based regimens in the relapse refractory setting. And that's probably why she did not have a good response with Chakraborty. We don't have much data in the frontline setting, though, with GAIN1Q21 in AL. So this is a slide quickly on supportive care. In the interest of time, I will skip fibril-directed treatments because this is mostly investigational currently, and we don't have any FDA-approved treatments which are fibril-directed, but this is clearly the future, and we are currently accruing on this randomized trial, the KL101 study, 301 and 302 in stage 3 and stage 3B study. With that, I would like to end and looking forward to the discussion with the group.
Thank you very much, Dr. Chakraborty, for really a very beautiful, very elegant discussion, but also you have very nicely highlighted and made the link between the current status of the literature and what happened to your patient. Thank you, Dr. Lentzsch, for being with us to discuss this case. So I will start the discussion with the diagnosis part, actually. And on your first slide, this lady was referred, I think, by the cardiologist, and actually she came to you with the heart biopsy already being done, I guess. So my question to both of you, is a biopsy, especially in heart involvement, the first recommended option, or maybe just a screening with NT-proBNP would be sufficient, then adding some imaging, but also you mentioned the strain. Where do we stand in this topic?
Yeah, maybe Raj, I jump in here because we have a lot of discussion with our cardiology colleagues. And we are in that good position where we get a lot of patients already with a tissue diagnosis. But once you have a patient and you have a suspicion of AL amyloidosis, for instance, MGUS patient with lambda light chain elevation and more shortness of breath, peripheral edema, absolutely start with a fat PET biopsy. What I would really recommend, fat PET biopsy, but then if there's amyloid tissue in the fat PET biopsy, mass spectrometry. This is really the gold standard, and given the fact, and that's a critical issue, that we can have patients with TTR amyloidosis, TTR cardiac amyloidosis, and an MGUS. We cannot really rely on an infiltrative cardiomyopathy and elevated lambda light chains, because that would lead to misdiagnosis. And to be very honest, we even had patients with TTR amyloidosis and light chain amyloidosis, mass spectrometry confirmed together in one patient. Then it becomes really tricky. But again, I think what I wanted to point out is you need a tissue diagnosis by mass spectrometry, regardless where the tissue is from. And you don't need to biopsy multiple organs. I had patients with 7 organ biopsies because the doctor thought that he needs to confirm the amyloid involvement in each organ. You don't have that. One biopsy is sufficient, and everything else we do clinically. And if the fat PET shows there's AL amyloidosis by mass spectrometry and the patient has elevated proteinuria or elevated cardiac markers, GLS, this is just cosmetic, helping you to determine really the stage. Again, one biopsy, mass spectrometry is sufficient. Don't biopsy each organ.
Excellent. Raj, would you agree with your mentor?
Yes, absolutely. Yeah, I think we at Columbia, we do get a lot of patients who already do have undergone heart biopsy, because our cardiology team is very skilled in performing endomyocardial biopsy. But I know that some community centers, their cardiologists may not be comfortable doing a heart biopsy. And in those patients, we don't have to. We can start with a fat pad and a bone marrow, and which are much less invasive before going on into a more invasive biopsy.
So let me ask another question about the diagnosis issue. Assuming this patient didn't go through the cardiologist, so we are in a scenario where you have a 77-year-old lady, I think, who is complaining and just coming to your clinic. She has an MGUS, I think. And what would be your step-by-step from the I would say the most simple into the most sophisticated investigation you would perform in this patient gradually? Because I guess unless you put them in the hospital for 1 week and then you do everything, but I don't believe it goes like this.
Raj, you want to start?
Yeah. So in this case, if lambda MGUS and if clinical suspicion of AL, I typically do fat pad and bone marrow together on the same day, because we can do in the clinic the same day to avoid wasting time. Because if fat pad comes back negative, then we have to bring them back again. And also doing them together in Mayo Clinic study has shown much higher sensitivity. So I usually do them the same day. And then I will start with an echo and a 24-hour urine, because those are fairly straightforward. So echo, we can do most of the time the same day, and the patient has to come back for 24-hour urine. So I would start there, a fat pad and a bone marrow, echo and 24-hour urine, and take it from there.
Yeah. Agree absolutely. Though I have to say, I have just had a patient recently as a really a center getting a lot of amyloid patients. We get a lot of patients with suspicion for amyloid. I recently had a patient who came back with amyloidosis of the lung that is very rare. I'm not talking about the localized amyloidosis, really the systemic amyloidosis of the lung. And the patient was fairly, I would say, not the typical amyloid patient, didn't have any shortness of breath, didn't have any peripheral edema, heart was pretty much okay. And we did not do the bone marrow biopsy right away. We said, okay, let's send the tissue for mass spectrometry and then also do lambda kappa light chains. So it turned out that it was a misdiagnosis of the local pathology. It wasn't amyloid. And also, in addition, the patient didn't have any elevated light chains and monoclonal M spikes. So we did not do the bone marrow biopsy. So if there are cases you feel clinically the patient can wait and something is right, I wouldn't jump immediately with all cases, into a bone marrow biopsy. But again, that was just an example, and that's usually rare.
Excellent. Does, by the way, the percentage of plasma cell infiltration has any value when it comes to AL amyloidosis?
Yeah, maybe I can discuss that. Usually, I would say the lower the percentage, the better it is, because you have a more MGUS-like type, and it's easier to really bring that patient into a complete remission. If you have patients, that clearly we have patients with 60% plasma cells, that is more like a multiple myeloma with a higher tumor burden, probably more difficult to bring them into complete remission, higher risk of abnormal cytogenetics. They behave more like a multiple myeloma. And don't forget, if we have patients behaving like multiple myeloma with a higher proliferation rate, we are missing the IMiDs pretty much in our, I would say, device, in our tools. I'm very careful with giving IMiDs because especially in heart amyloidosis patients. So, and we don't have experience with the BiTEs. We kind of, are more restricted with we don't have CAR T cells. So the higher the percentage infiltration rate, I think the more difficult the treatment is and the prognosis.
But then you mentioned the biopsy, but also the cytogenetic abnormalities. And please, Raj, remind me, I think you looked for gain 1Q in this patient, and she had 3 copies. But I didn't notice whether you systematically look for translocation 1114. Is this like, part of the package, or is this something you would do later?
Yeah, no, we did systematically look for the chromosome 14 translocation. I just mentioned the positive ones in the slide, but we did systematically look for all of the probes, including chromosome 1, hyperdiploidy, chromosome 14 translocation, and 13q deletion.
So, Suzanne.
Yeah, the Heidelberg group did extensive work on this. The problem what we have, regardless what your cytogenetics are, you don't have a lot of tools. Yeah.
So that was my question, that beside translocation 1114, where obviously venetoclax can be a useful tool, what is the value of the other abnormalities? And here we know gain 1Q, probably bad prognosis, but did we really need gain 1Q to know that an advanced heart amyloidosis has a bad prognosis? I'm trying to be provocative.
Yeah. I think it's an excellent question. If somebody has really high-risk cytogenetics, I would probably go to my transplanter and would bend the arm and would say, hey, listen, I don't think that with Dara-Cyborg, these 6 cycles, we can really kind of, achieve a long-term remission. And even if the patient is older, we just transplanted somebody who was 70, you always recall the recent cases. But I think that's important to say that we recognize more and more that cytogenetics plays a role in. I truly think, Mohammed, and you will probably like it, that we cannot write transplant off too soon. Yeah, I think transplant is an excellent, and if you go back to the data, patients are in remission for 10 and even more years, or even kind of there's a cure. So I would say high-risk cytogenetics, please consider transplant. It's a good treatment for AL amyloidosis, if it is safe,
Excellent. Thank you very much. And by the way, even as a transplanter, I was very pleased to get rid of transplant and CML. And we're all very happy, getting them cured with a TK inhibitor. So let's move to the treatment, because I think Raj, you did really a great job giving the historical evolution with the trials from Dr. Kyle with colchicine, but I think he did something with vitamin E at some point, and so on. And then you mentioned this famous Rajshekhar French trial comparing melphalan X versus transplant, where I do agree with you, non-relapse transplant-related mortality was extremely high, something that it is a little bit unexpected, at least for me, because today, in myeloma, for instance, non-relapse mortality is less than 1%, assuming in amyloidosis is slightly higher, but I wouldn't imagine it's more than 2 or 3%. So one question that comes quickly when it comes to transplant in amyloidosis, especially if they have heart involvement, is about stem cell mobilization and the risk of arrhythmia. Is there any practice of putting systematic pacemakers or whatever intervention? What's the opinion of your cardiologist?
So number one, you're right. And what we do is when we mobilize stem cell patients with AL amyloidosis, we do that inpatient. Yeah. So we think sometimes it's an overkill, but usually it's a quick admission over the weekend, and we put them on the monitor, and we have very good experiences with mobilization as an inpatient. Number two, we usually discuss it with our cardiologist, and they're very careful with pacemakers. So don't forget, the amyloidosis is an infiltrative cardiomyopathy, and the amyloid is like an insulation of the nerves, conducting, the electricity and giving the impulse for contraction. So even if patients have pacemakers, they usually die from kind of, pulseless cardiac arrest, because there cannot be I would say, in contraction due to the amyloid that functions as an insulator. So we are a little bit more careful with pacemakers. I think most of the patients who have a pacemaker come already with a pacemaker from outside. But again, it's a case-to-case decision by our cardiologist. I mean, we have met Mauro in our institution, and this is really kind of, a superstar in cardiac amyloid, and he really helps us a lot to manage those patients.
Excellent. Thank you very much. Raj, anything to add about how to handle, because they are usually elderly patients, and even without amyloidosis, they come, at least in my experience, with a long list of anti-hypertension drug, beta blockers sometimes, aspirin, whatever. How do you handle all this?
Yeah, so I think one thing I couldn't spend much time, because of lack of time, but multidisciplinary care is very important, because it's not only the hematologist, but also the cardiologist and sometimes the nephrologist, who have to be involved. And most amyloid centers, like ours, we have once a month, multidisciplinary meetings, like a tumor board about all of the patients. And that's, I think, very important. And typically, they do not tolerate beta blockers and ACE inhibitors well. So when I first see them, if they are on a beta blocker and ACE inhibitor and blood pressure is on the lower side, I will usually stop it even before they are seeing a cardiologist. But sometimes if they've already seen a cardiologist, they have already undergone that medication optimization by the time they come to us. But I think it's kind of a teamwork usually with the cardiologist and nephrologist.
But one thing, Mohammed, I wanted to really mention on concerning the beta blocker. Ask the patient, why was a beta blocker started? Usually it's a cardiologist who sees that the patient has a frequency of 100 and more, and then a beta blocker is given, but that's the wrong treatment. Patients with an infiltrative cardiomyopathy need a higher heart rate. It's because you have a low end diastolic volume, you have a low stroke volume, and the heart is compensating that. Low stroke volume, and then with a higher heart rate can compensate. If you lower the heart rate, the stroke volume, or the kind of, volume in the minute, is so low that the patient feels very bad. So that's why beta blocker, be really careful with this.
Excellent. Thank you very much. Let's move now to the last part about the response to treatment. And I think, Raj, you have shown a nice slide showing that in the heart, it can take more than 9 months to respond, although this was before the DARA VCD era, I would say. But on the other hand, I always learned from Dr. Merlini that usually you would treat the amyloidosis patient for 9 to 12 months in general. So here it looks to me that specifically in the heart, you may need to go a little bit beyond, especially if they didn't respond well.
I think if I can chime in, so I think, the main determinant of response in the heart is a hematologic CR. And typically patients can achieve a hematologic CR, especially with Chakraborty, within 2 to 3 cycles even. So we typically do 6 cycles. I typically do 6 cycles of Chakraborty. And then at that point, if they're in a hematologic CR already, and if they are MRD negative, I typically do not do daratumumab maintenance, but if they are MRD positive, which is most of the patients are usually MRD positive at that point, I will do daratumumab maintenance. But I don't think once they're in a hematologic CR, I don't prolong treatment just for the sake of response in the heart, because the median time to response is 9 months, but we do see a significant number of patients with earlier response too. And even before the daratumumab era, Dr. Merlini's group has shown that even at 3 months there is a subset of patients who respond based on the NT-proBNP. So that's what I would say. I'm curious to see what Suzanne thinks.
Yeah, I think it takes time before the macrophages, that's most likely eat away the existing amyloid. And the macrophages can only be successful if there's no further build-up, So that's why we have to bring patients in a complete remission. We have to stop to build up amyloid, and then the macrophages eat the amyloid. That's very non-scientific, but I always explain that my patients, if you have a hematoma, you first stop the bleeding, and then you hope over the time, that the hematoma is resolved, and that takes with amyloid. I think it is important to tell that the patient to really set expectation. The patient comes and you have to say, listen, I treat you for 6 months, you will be busy, you will feel better a little bit, but it's baby steps, and it will take a year until you will see a significant change that you might go back to your normal life. I think that knowledge that it takes longer to have organ response is important for the patient to really set expectations.
Well, I think these were lovely words. We would like to conclude this educational activity. I hope you have enjoyed it. So first of all, congratulations to you, Raj, for a really lovely case, but I think you did a fantastic overview. Well done. Thanks to your mentor, Dr. Lentzsch, and congratulations for this really amazing multidisciplinary work and program you're doing. I think this is helping and advancing the field a lot. So I hope everybody has enjoyed it, and we have been very pleased and honored having you with us. And as I always say, wherever you are, please, guys, stay safe and keep well, and see you soon.
Thank you, Dr. Moti, for this effort. Thank you so much.
Thank you.
Take care.
Thank you,
Bye-bye.
Dr. Moti. Bye.
Bye.